I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Arnold Milstein, a professor of medicine at the Stanford School of Medicine and director of the Stanford Clinical Excellence Research Center. Dr. Milstein has written a perspective article about reducing healthcare costs by creating a learning health system. Dr. Milstein, what do you and the Institute of Medicine, which has issued a report on this, mean by a learning health system?
Well, Steve, historically, most clinicians and frontline health workers viewed their job as taking existing science and doing their best to apply it in ways that would benefit their patients' health. And the notion of a learning health system extends that in two ways. The most important way is that it asks healthcare workers, including physicians, to take on a second major role beyond delivering care, and that is the role of continuously examining current methods of delivering care and asking the question, are there ways in which, through how care is delivered, we might further improve patients' health? And so it is expanding the job description from simply providing good care to continuously examining care processes and hypothesizing new and better ways of creating and supporting patients' health goals. The second way in which the notion of a learning health system builds upon, historically how most clinicians have viewed their work, is it also implicitly asks clinicians to think about goals for the healthcare system beyond their patients' immediate health goals. The essence of that broader set of goals addresses what the Institute of Medicine has referred to as value. This moves beyond what has historically been the main focus of clinical work, which has been to improve patients' outcomes, and to begin to put on a more equal footing patients' experience of the care process, which is an important aspect of outcome, but many clinicians have not viewed as perhaps as important as the clinical outcome itself. Another element of this notion of value that historically has not been a primary focus of clinician thinking is to ask the question, how do we not only maximize how what we do helps the patients reach their personal health goals and do it in a way that creates the most favorable possible patient experience of their care, but also how do we do it in a way that best conserves society's pool of resources that has been set aside to pay for health care. So it's the second primary way in which the IOM's vision of a learning health system differs from when I was a medical student and in medical training, is this notion of thinking about not just the patient in front of you, but also the patient as a representative of society as a whole, which basically funds the healthcare system with income that they forego, whether it's in the form of payroll deductions or taxes that they pay.
So what new qualities would need to be fostered to create such a system in the United States?
Well, probably the single most important change would be to train healthcare workers, both people who are in the course of learning to enter the health professions as well as those who are already in the health professions, to view the care process itself as a target of problem solving. That is, rather than to presume that how we provide care today is the best possible way of applying known medical science and existing biomedical technologies, but to train both current and future healthcare workers to regard their work as a hypothesis, and that every day they ought to devote some effort to re-examining and ask themselves, how might the way we're currently delivering care now might be modified in order to offer an opportunity to deliver more value to our patients, and following that hypothesis, to work with one's colleagues to design tests of those hypotheses, whether in small scale or large scale, and examine whether or not indeed the three elements of value were improved. If they were, to take responsibility on an ongoing basis for embedding that in how care is delivered, and if not, then to wake up the next day and to begin to focus as a team and as an individual on imagining and then potentially testing a different hypothesis.
And what are the barriers getting from here to there?
Well, I think the primary barrier has nothing to do with healthcare. It has to do with innate characteristics of all humans, and that is I think it was beautifully laid out in Daniel Kahneman's recent summary of psychological evidence on human mental propensities called thinking fast and thinking slow. Humans are designed inherently to be conservative of mental energy and attention. And accordingly, the biggest barrier to this notion of a learning health system unfolding is how biased we all are without realizing it toward wanting to do the easiest thing, which is what we, in this case, performing our clinical jobs today identically as we have done it yesterday and the day before. That is, we are strongly biased toward habitual behaviors, and a learning health system poses a direct challenge to that innate inclination of human beings.
In your article, you describe provider and patient-directed incentives for improving healthcare value, but the incentives may not help if physicians and healthcare organizations don't know how to go about actually improving the care and the value of the care they deliver. So what should they be doing to begin creating more bang for the buck?
Well, I think the best place to start would be to examine what is now beginning to emerge as America's dashboard for enabling one provider to compare their value to their patients relative to their peers and other institutional providers, and to begin to invest effort in understanding what one's peers who are generating more value for their patients, how they are doing their jobs, and then begin to ask oneself, what hypotheses does that imply with respect to how we conduct our care delivery processes? I think the nicest example to sort of go back to, and I wish I had the reference readily at hand, but it is easily searchable. And that is the account of a clinician at St. Peter's Hospital in Albany, New York, which was written up in one of our respected peer-reviewed journals, as to the process that he and his colleagues went through when New York about 15 or 20 years ago broke the ice nationally with the first risk-adjusted comparison of clinical outcomes during hospitalization from coronary artery bypass grafting. And the clinician's article basically describes his thinking when at first he found out and his team found out that their risk-adjusted mortality for that form of cardiac surgery was dismal relative to peers in New York. And after an initial process of understandably wanting to make sure that the comparisons were valid, which didn't fully satisfy him but satisfied him enough, he and his team then went to one of the centers in the state of New York that had outstanding outcomes. This was NYU. Observed what his peers were doing, and from that, as the article described, generated multiple hypotheses as to how the care process in Albany, at his hospital in Albany, might be improved. And then, the article ends with exactly what those who advocate for a learning health system, would hope for, which is a very substantial improvement in risk-adjusted mortality for his hospital's cardiac surgery service. So, step one is, in the absence of us, at least at the beginning, we don't have a nationally robust system for training healthcare workers and physicians in what does it mean to be a robust participant in a learning health system. The easiest place to start is simply to begin to mine many of the comparisons initially at hospital level and over time at the individual physician office level, and begin to become curious as to what peers who are ranking much more highly on value, how they're doing their work, and use that process of examining peers with superior outcomes to begin to generate some initial hypotheses. Meanwhile, the good news is that even though our training resources in the U.S. for how to be a participant in a learning health system are limited, there are nonetheless a number of admirable organizations that are pushing forward on this front. After disclosing to you that I'm a member of the board of the Institute for Healthcare Improvement in Boston, I would certainly cite IHI as sort of what is, I think, both globally in the U.S. is one of the leaders in this area, but they're by no means the only resource. There are multiple other organizations dedicated to this effort of benchmarking and the enablement of improvement hypothesis generation, but the IHI is certainly a nice illustration and probably the largest such organization operating in the U.S.
You note in your article that physicians have successfully resisted policies that threaten their incomes. Do you see a lot of that kind of resistance going on here?
That is why I refer to this moment as a nationally momentous moment, because it is one of those times when I think physicians are being asked to sort of think more broadly, beyond self-interest and consider the self-interest of other citizens here in the U.S. and to begin to reflect on the opportunity cost of not acting, even though that that action is not necessarily in one's own self-interest. I mean, I think as clinicians, we're in some ways from the beginning, and in some way we're drawn, to this kind of thinking. As trainees, we're for many years, those of us who went into medicine realized that the kinds of personal sacrifices that were required in terms of time and exhaustion levels, fortunately, those have been somewhat diminished in recent times. But medicine was regarded as a calling and something that, by definition, did not involve optimizing one's best interests when patient benefit was at stake.
Given what you say there, in what ways do you think physicians should be leading this charge?
Well, the reason I believe that physicians should be leading the charge is that no one could do it more effectively. Many have commented that the single most powerful determinant of the level and cost of resources used in the healthcare system is physician decision-making and physician behavior with respect to the influence that physicians uniquely have on patients' health behaviors. But even more important in the current environment in which many of the most effective solutions or plausible solutions to improving the value of the American healthcare system hinge on American politics. My belief is that the public attaches credibility uniquely to the judgment and opinions and what their doctors say about healthcare. And I think this is a moment in which if physicians were to speak up in support of incentives to better reward value, be it through so-called value-based pricing of services or value-based insurance design, I believe it would have an enormous impact on the public's view of strengthening incentives for value and therefore the political feasibility of not only increasing the use of those incentives, but also better harmonizing them across American healthcare payers. Implicit in my last comment is the challenge that even if every individual payer of healthcare, whether it's a government payer or a private insurance company or a self-insured employer, but if every payer is differently defining value and or is using very different means of encouraging it, that outcome, which is what we currently have in this country, will be a much less clear signal to America's healthcare industry that value will be rewarded.
So finally, how optimistic are you that we'll begin to bend the healthcare cost curve in this country?
Well, I would say that clearly the pessimists have an advantage, in this debate because historically we've not, succeeded terribly well as a nation in beginning to limit growth in healthcare spending as a percentage of our national income, which is our ability to afford anything. So if neutral judges were to, listen to an argument, I think the pessimists would likely hold sway if the judges believe that the past is the best predictor of the future. The thing that I think is most interesting and contains the most possibilities in terms of, continuation of national prosperity broadly here in the U.S. is that I believe that many American physicians are becoming sensitized to the unintended effect they are having on the federal government's level of fiscal stress, as well as to the impact that the healthcare system is inadvertently having on the global competitiveness of American workers and their employers. And I believe that the signs of this are around us. For example, over the last 10 years, the signing by the majority of American medical specialty societies of the physician charter, a committing physicians to a new and not very well articulated facet of the Hippocratic Oath, which is a commitment to conserve society's limited pool of healthcare resources. That's not a quote from the charter, but that's, if you go through the charter's language, it's sort of couched in terms of assuring a just distribution of society's healthcare resources. And I think the most tangible and most recent evidence of this openness of physicians to thinking about the welfare of the nation with respect to impact of healthcare spending is the Choosing Wisely campaign, which is sort of the first organized multi-specialty effort to begin to acknowledge that there's a very substantial list of things that physicians could do to improve the affordability and thereby the value of healthcare.
Thank you, Dr. Milstein.